So I would like to take this opportunity to introduce our second speaker, which is Dr. Victor Lee. So Dr. Lee is currently a consultant radiologist at the Chinese University Medical Center. He completed his medical degree at Faculty of Medicine at the University of Hong Kong, and he received radiology training in Queen Mary Hospital and obtained his fellowship at the Hong Kong College of Radiologists in 2019. His subspecialty interests include musculoskeletal imaging as well as intervention. He has published more than 30 scientific articles in various local and international peer-reviewed journals, including radiology and also muscle and nerve. He's a colleague who actually pioneered and specialized in the application of ultrasound MRI fusion navigation for target muscle biopsies and in myopathy. So without undue delay, it's your time, Dr. Lee. Thank you.
Thank you, Dr. Chan, for the kind introduction, and thank you for the invitation for me to share my 2 cents on neuromuscular imaging. Actually, in my days during my training in Queen Mary Hospital, which is not long ago, the use of muscle MRI was really very limited to the clinical scenario of infection or muscle trauma. So it was not until I met Dr. Gao in Queen Mary Hospital when I developed some of my interest in muscle MRI. So I think the ongoing and continuous clinical dialogue between radiologists and neurologists is very important for development of a muscle MRI service in the institution. So today I will there's some disclaimer from Sanofi, and so this is the outline of my talk. I will try to illustrate how some of the basic principles of muscle MRI for neuromuscular disease with focus on Pompe disease. And I will provide you some update in literature regarding muscle MRI in Pompe disease. And finally, I will try to show you how I usually do image-guided muscle biopsy. I think muscle MRI is a very straightforward diagnostic imaging, but it's at the same time very complicated. It's straightforward is because there are only 3 imaging parameters or features that we want to interrogate or look at in a muscle MRI, and they include muscle bulk, fatty infiltration, and inflammation or edema. So for muscle bulk, we just want to look at whether the muscle is enlarged or atrophic. For fatty infiltration, actually signifies there is some chronicity of the problem, and we usually do this, assess this in T1 weighted images. We look at the fat signal as previously taught by Dr. Nishino, showing that fatty infiltration will show increased amount of signal in T1 weighted imaging. And inflammation or edema signifies there is some active problems going on within the muscle, and we usually assess this in T2 weighted image with fat suppression, and usually the muscle edema will show increased signal in T2 weighted images. If we want to have a more objective parameter to compare the severity of fatty infiltration or edema between serial study, there are nowadays specialized sequence, what we call a quantitative MRI that we can do. For fatty infiltration, we can actually, for fatty infiltration, we can do what we call a fat fraction map, which I will show you in a moment, that we can just measure on the fat fraction map and measure the percentage of fat signal within a region of interest. And for edema, we can do a sequence called a T2 mapping, and we can measure the T2 value. The higher the T2 value means that there is more water signal within a region of interest. There are some researchers or scientists use MR spectroscopy to interrogate the presence of metabolites within the muscle. For example, some would use H1 or carbon-13 spectroscopy to interrogate the amount of glycogen accumulation in muscles, and some would interrogate the presence of muscle metabolites involved in energy processes using phosphate spectroscopies. However, these are is not widely or commercially available in routine clinical practice. So in short, I think the typical protocol for a muscle MRI is quite simple. Mainly T1 weighted image look at the fat signal, and T2 weighted image with fat suppression to look at the water signal. And most commonly, we in my usual practice, I encounter more of the MR thigh request because of the because thigh muscle are usually the most common site of involvement in many neuromuscular disease. You can see the normal appearance of muscle on T1 weighted images that patients should have a symmetrical and normal muscle bulk. There can still be some small amount of high T1 signal within the muscle or in between the muscle, suggestive of intramuscular and intermuscular fat. On T2 weighted images, edema should not present in normal muscle, but what we can see is we can still see some linear T2 hyperintense signal in between the muscle or within the muscle, and these are blood vessels. So fatty infiltration means chronicity of a neuromuscular disease. So it is a imaging hallmark for muscular dystrophy and some of the metabolic myopathies such as Pompe disease. However, it can actually occur in many of the end stages or the chronic phase of other myopathies such as inflammatory myositis or denervation injury. On your right-hand side, you can see this is an example of a patient of an MR thigh muscle taken from a patient in poliomyositis. You can see there is severe fatty infiltration with of the posterior calf muscle. The soleus muscle is the appearance is just like the subcutaneous fat, suggestive there is near complete replacement of the muscle with the fat. With less severity, you can see there is still some muscle fibers within the muscle. And this, sometimes we call it a moth-eaten appearance. Normal muscle look like this in contrast. We can also quantify the severity of fatty infiltration by semi-quantitative technique. The most commonly used scale is called mercury scale, which is a scale from 0 to 4. 4 means complete fatty infiltration, and 0 means no fatty infiltration. This is the fat fraction method I'll talk about. This is a specialized MRI sequence using a Dixon technique for fat saturation. The actual use of this sequence is quite simple. We just actually have to measure, put a circle and a region of interest, and we can measure the amount of fat fraction or the percentage of fat signal within the muscle. And I think this may be useful for serial comparison between different study. And you can see the subcutaneous fat is, in this case, red in color, and suggestive is completely fat, whereas it's normal muscle, there should be a low fat fraction. In contrast, T2 weighted images with fat saturation help us to detect muscle edema. And muscle edema can occur in a lot of different disease processes, includes inflammation and denervation. For example, in this patient with peroneal neuropathy, we can see denervation edema in the peroneal muscle supplied by the peroneal nerves. And in contrast, in this patient with dermatomyositis, we can see multifocal muscle edema together with fascial edema. So MRI is very important, is very helpful not only to look at the muscle itself, but also the supporting connective tissues such as fascia. And it can also occur, muscle edema can also occur in patients with leukocytic myopathy, in which the muscle biopsy won't show inflammatory infiltrates, but just necrosis. This is a patient with anti-HMGCR leukocytic myopathy. There are some special characteristic pattern of edema. For example, in this case, anterolateral predominance, muscle edema involving the rectus femoris and the rectus lateralis muscle, and in the posterior thigh, they usually the membranosus and the long head or biceps muscles are involved with relative sparing of the short head or of the semi-tendinosus muscle. So we as radiologists use pattern recognition to diagnose problem. I would say the detection of myositis is not difficult on an MRI, just like we can easily differentiate a zebra from a horse. But there are significant overlap between the phenotypic appearance or MRI muscle involvement pattern between different muscular dystrophy or inherited myopathy. I think the task is quite difficult, just like we have to differentiate different subspecies of zebra. So when I prepared this talk, I also because artificial intelligence and also machine learning is a very hot topic, and I come across this paper which is very interesting. It has shown this paper is a paper taken from neurology already 3 years ago. A group of scientists in Spain tried to develop AI tools with around 1,000 lower limb MRI, and they have already shown that the AI tools to use to differentiate 10 muscular dystrophy is already very accurate. The accuracy described was up to 96%, outperform many of the expert diagnoses. So this poses a worry that I may become jobless in a few years' time. But and for your interest, the Pompe disease is within this cohort as well. But still, I think it's important that we know about the typical MR imaging pattern of Pompe disease before the development of a very reliable AI tools. So, Dr. Li and also Dr. Ho has already pointed out there are two main phenotype of Pompe disease: the infantile onset and late onset. Most of the literature shown that I can find is that is on late onset Pompe disease. Infantile onset Pompe disease does not have very characteristic MRI features. So I focus on the imaging features of pattern of fat replacement in late onset Pompe disease. There are a few characteristic features. The first one is early and predominant involvement of the tongue. There is significant tongue fat infiltration that will correlate with the clinical presentation of tongue atrophy. And easier to remember pattern is the proximal muscles are involved, and these include the shoulder girdle muscles, gluteal muscles, the trunk muscle, including the paraspinal muscle, psoas muscle, and the abdominal wall muscle. In the thigh, very easy to remember is that the adductor magnus, the larger muscle, and also the long head or bicep femoris show fat infiltration earlier than other thigh muscle. And I think that there is two proximal to distal gradients that we can that is a characteristic in the pattern of fat infiltration in late onset Pompe disease. The first proximal distal gradient is there is greater within the same muscle. For example, a rectus lateralis muscle, the proximal portion of a particular muscle is involved first, whereas the distal portion of the muscle is involved in a later stage. And the second gradient is that the thigh muscle, the proximal thigh muscle, is have an earlier or greater involvement than the leg muscle. So this is the example taken from a paper showing that is we are looking at whole body MRI in a T1 weighted sequence. So we are looking at the fat signal. You can see that it's fatty infiltration of the tongue, the subscapularis muscle, the latissimus dorsi muscle, and when we look at the axial cut in the level of abdomen, we can see there is fatty infiltration of the internus oblique muscle and the transversus abdominis muscle. And also posteriorly, the psoas muscle and the paraspinal muscles show severe fatty infiltration. And for the gluteal muscles, the gluteus medius and minimus muscle are involved, has more severe involvement than the gluteus maximus muscle. And in the thigh, a predominant muscle that is involved by fatty infiltration would be the adductor magnus muscle. Um, Although the clinical hallmarks of late onset Pompe disease is fatty infiltration of multiple muscles, muscle edema still occurs in around 1/3 of patients. And the predominantly involved muscle with muscle edema will include the adductor magnus, semimembranosus, and bicep femoris muscle. We still don't know why there is increased T2 signal or muscle edema in late onset Pompe disease, because there is actually no inflammation infiltrates in the muscle biopsy. Some propose that there may be due to some degree of muscle necrosis, or some propose that there is increased water retention from glycogen accumulation, but the exact mechanism is still unknown. But what we know that if there is muscle edema in a muscle, the degree of fatty infiltration in follow MRI will be higher, suggestive there is active problem going on. So this again a example of increased T2 muscle signal or muscle edema in a patient with late onset Pompe disease, pre-asymptomatic. We can find that there is a multifocal bilateral increased T2 signal in anterior thigh and posterior thigh muscles. However, if you just give me these kind of these pictures or this MRI, it would be it's just not so different from other inflammatory myositis or necrotizing myopathy. Is quite difficult. So I think the importance of we still don't know the exact importance of these muscle edema, but we know that there is some active problem going on. But I think these muscle edema may be a good target for muscle biopsy if we really need to do one. So we know that the MRI can be helpful in monitoring the treatment response in patient in Pompe disease who receive enzyme replacement therapy. But what we know is that the MRI change of fat replacement is quite slow. In the one embassy trial, in a patient who received enzyme replacement therapy, although after treatment, the percentage or the presence of glycogen in muscle will decrease at 6 months, there is actually not much change on MRI. So this may give us an implication on how frequent we can do follow MRI in this group of patients. What we know is that if the average yearly progression rate of fatty infiltration in patients who receive enzyme replacement therapy still exists is around only 1 to 2%, and the fat replacement rate can be lowered by 0.7% per year when compared to untreated patient. This table, this graphs show that if the muscle has initial no muscle edema, the enzyme replacement therapy can completely stop the process of fatty infiltration. Whereas in muscle with muscle edema, there is still ongoing fatty infiltration in follow-up study, but the rate of fatty infiltration is decreased. Just a short slide for infantile onset Pompe disease. Actually, there is very limited data. In early MRI study, before the introduction of enzyme replacement therapy, there is very limited data because it's very difficult to do an MRI in a small child or an infant. So the not to mention is a MRI study or research. So what we find if we do an MRI in infantile onset Pompe disease in first year, probably we won't see anything. The most we see, at most we can see there is some muscle hypertrophy, probably due to the accumulation of glycogen. In patient or children who with Pompe disease treated with enzyme replacement treatment, we may see some fatty infiltration of epithymus or thigh muscle, or we can see some muscle edema in thigh or calf muscles. I would say these can be seen at a milder form of late onset Pompe disease, because I think as described in previous speakers, I think infantile onset Pompe disease and a late onset Pompe disease is a clinical spectrum, and so people, children with infantile onset Pompe disease treated with enzyme replacement therapy may actually be a milder form of late onset Pompe disease. This at least what we can see on MRI. You can see there's only mild fatty infiltration on tongue in the epithymus muscle and the tongue muscle. So this is the last part of my presentation. I'll talk about how I do muscle biopsy. There can be different ways to select a muscle for muscle biopsy in myopathy. We can select by clinical examination, by EMG, or by MRI. In a study by on muscle biopsy in patients with suspected idiopathic inflammatory myopathy, it has been shown that if we use MRI to select a muscle, there can be a decrease of false negative sampling rate from 23% to 19% in this study. But I think the problem of just the limitation of MRI still exists because a muscle can be involved only partially, and sometimes it's not. So that's why I think ultrasound MRI fusion can be a way that we can increase the diagnostic yield, because we can target exactly the area of edema that suggests active problem going on within a muscle. So that is how we do ultrasound MRI fusion guided muscle biopsy. First, the patient receives an MRI usually fine, and we can detect, for example, in this case, there is muscle edema in the left semi-membranosus muscle, and we want to target this muscle for biopsy. We can import the data of an MRI fine into the ultrasound machine through a process called plane and point registration. Basically, in simple terms, it's just to give the ultrasound machine an idea the anatomical landmass, and we can after this process, we can have simultaneous display of the MRI together with the ultrasound. So when we move the ultrasound probe, actually the MRI will update simultaneously with the ultrasound. And that's why we can find the area of muscle edema and have a real-time target of the area of interest, like the edema area, edematous area that we want. Hopefully this can improve the diagnostic yield. So this is the way that we do it. And you can see this is the same patient with muscle edema with in the left semi-membranosus muscle. And after fusion, we can find this muscle on ultrasound that is confirmed with the MRI's updated images. And you can see it on ultrasound, it's very difficult for us to see any muscle edema. This muscle has no significant difference with the adjacent normal muscle without muscle edema. So I think the potential benefit is that of this fusion is that we can target the muscle, not only the muscle, but the muscle area that is edematous. And hopefully we may be able to target the area with most active problem. And we can avoid muscle with fatty infiltration, and finally, we may be able to give increase the diagnostic yield and have a better radiopathological correlation. Oh, and this is my last slide. Some take-home message is that muscle MRI is helpful in assessing various neuromuscular disease, both morphologically and quantitatively. And late onset Pompe disease has characteristic pattern of fatty infiltration, including the involvement of tongue and the proximal muscles. And ultrasound MRI fusion may be helpful in the diagnosis on neuromuscular disease. Okay, and with this, I conclude my presentation, and I welcome any question.
So thank you very much, Dr. Lee, for the very comprehensive literature review, and also introduce to us your MRI ultrasound fusions technology to guide to find the most target and the muscle biopsy that we can locate at. Yeah. So is there any question from the floor? Yes. Professor Nishino?
Yes. So the combination of ultrasound and MRI guided muscle biopsy is very interesting and probably very useful. But I wonder if you do needle biopsy or open biopsy for this.
Thank you for your comment, Dr. Shino. We do needle biopsy to target the area because as we have discussed, the quality, the size of muscle cores taken by needle is actually much smaller than surgical. So we hope that these kind of most targeted areas of edema can increase the diagnostic yield. I think another way, one of the very good research topic will be what would be histological difference between the muscle biopsy taken with the area with muscle edema and without muscle edema in a myopathic patient with a systemic involvement, and that was a very interesting topic to know. Yeah.
I actually wonder, so as we discussed, we do open biopsy, and we strongly recommend open biopsy rather than needle biopsy. But so after opening the fascia or the skin and fascia, I wonder if you can do ultrasound over the fascia, or even after opening the fascia, then directly onto the muscle. Then I wonder if that might be helpful, to further characterize the abnormality in the muscle or target the biopsy site.
One thing I think what we can do to improve the ultrasound MRI fusion technique is that we may for example, before the surgery of muscle biopsy, we may do a fusion first and mark the entry site. If we want to do a open biopsy, then we know the surgeons will have a better idea on how to get to the area with edema. Another point will be, I think we can try to increase the biopsy core size. And because I think the benefit of needle biopsy is that there's a smaller wound and we can be more targeted. Yeah, but I think I do agree that the quality of muscle by surgery should be helped.
Yeah, beyond the target, I mean the selection of the biopsy site, as far as I understand, the echogenicity and the quality and texture of the echo, is affected by the the tissue between the target area and the probe, right? So if you really open and directly put the probe onto the muscle, I think the echo image will be different. That's what I suspect. And
yes.
I wonder if this may characterize, this may help characterizing the inflammation or whatever, fat infiltration, or even the glycogen accumulation, and it may help differentiating the pathological changes. And it may be interesting to compare actually the pathology and the echogenicity.
Yes, I think it will be a very interesting topic to do research in. Yes, I would say. And one of the is also sometimes the muscle edema is very difficult to be visualized by ultrasound. But one of the interesting thing is that when we do MRI fusion with ultrasound, when we are looking at the particular muscle at the particular area, we start to see some very subtle changes. It's just like when we know that there is some abnormality with more clear, more hard, try to search for it, then we see very subtle changes. But I can say the changes is really, really subtle in some patients.
So we also have a question from online. It's actually from Dr. Alan Lau, and the question is, how do we differentiate myositis or other inflammatory myopathy from Pompe disease using MRI?
As I've mentioned, just myositis will have usually have a pattern of muscle edema, a lot of muscle edema on T2 weighted images, and of course, Pompe disease can sometimes have muscle edema. So we, based on the pattern of edema, that we can have some idea. For example, Pompe disease have muscle edema of epicondylus, some of the very or larger muscle on the MRI. And also and another very important point is that the degree of fatty infiltration, because fatty infiltration is actually the hallmark of Pompe disease. And after all, and also the clinical presentation will be very it will very important. And I always rely on my clinical counterparts, my neurologist colleagues, to tell me what they look like. What is the more likely diagnosis even before the imaging, and we can always discuss. Yes.
I would like to ask the last question. You mentioned in the infantile onset of Pompe's disease, like the MRI actually show non-specific changes. I also have an experience of a very weak baby, actually is a twin with congenital myopathy. Actually, the MRI couldn't find anything. And then I got to know that MRI actually needs to pick up the muscle fiber of certain size before they can actually pick up the signal changes. So I was wondering actually what is the best age we need to consider when we want to use MRI imaging to assess the muscle pathology?
I think there is no lower limit of muscle size that we can detect the signal actually. I think because for smaller kids, we can always use for example, a dedicated smaller coils, for instance, surface coil, to increase the signal of a small areas, because in neuromuscular in musculoskeletal imaging, we even we always image the MI finger as well. I think that is, we can still see some signal changes if there is problems going on. So I think size itself is not a really a problem. Rather is the availability of MRI and how to coordinate, for example, sedations, those methods that will limit the availability of MRI actually.
Yeah. I'm asking this because like we have a very severe Pompe disease. Now I think the last patient we have already passed away is still very weak. So I can't imagine like so weak with cardiomyopathy and they're not moving, and the MR is actually non-specific. So that's why I have this question. And I was wondering how the ultrasound can help, but I actually don't know the answer. Thank you very much, Dr. Lee. Let's thank him again. Everyone.
Thank you very much.